And she's the member of the expert group with the Ministry of Health and Family Welfare for the National Program of Palliative Care. She's also the honorary secretary of Indian Association of Palliative Care. She is one of the founding members of eHospice India, and she has been the student representative for international students at Cardiff University. She is representative for North India in Central Committee of IAPC in the year 2000, in the period 2014 to 16. She is the one who launched the first online bereavement support website in India. With 6 international medical journals and 2 research projects in her name as publications and 16 recommendations for awards. She's also awarded with the leadership in palliative care in Southeast Asia in the year 2019. So it was my privilege to introduce you to this cohort, Dr. Savita, and it is over to you.
Thank you so much for the kind introduction, and welcome to all the participants for this very important session. I would like to just introduce myself that I am now in Tripura. So that was my detail earlier when I was in Gwalior, but now I'm in electricity as well as has gone off. So I have joined with my phone, and please excuse me if there is any disturbance in the voice or the picture quality, or it goes off suddenly in the middle. So we have to bear with that being in remote areas. But yeah, as you can see, Parul Rena is writing audio quality is not good. So I'm going to switch off my video now so that, the audio will be better, and then I'll be starting my presentation. Okay, so I will be talking about
Sorry to interrupt, ma'am, but
the factors which affect the accessibility to opioids for our patients. And I'm sure you must study, and some of those who are new, why we are discussing this topic, because those who have HIV, 50% ambulatory. Yes. Not only cancer, but HIV as well as patients with CHF have moderate to severe pain, which affects their life, social interaction, increases risk of suicide, and makes life very difficult for their families also.
Ma'am, we are not seeing your screen. Sorry for interrupting.
My God, this is something really bad today.
If you want, maybe we can share the screen from our end.
Let me see. If I'm not able to, then I'll tell you. We'll try just once.
Okay, sure. Yes.
Is it okay? Yeah.
Visible. You just have to put in the slideshow mode. Perfect, ma'am. We are good to go.
All right. All right. So the patients with pain, they remain undertreated throughout the world because since it's not a part of our undergraduate education, it remains inadequately recognized, assessed, as well as treated, and less than 4% of patients in India are able to get adequate relief. And out of the patients that we treat, almost 85% may have pain because of their disease, but 15% they will have pain because of the treatment. And it's important because it forms the stepping point for most of our patients who come into palliative care. And there are many studies which show that doctors fail to appreciate the severity of the pain in their patients. And whatever figures we may have for quantitative studies, there is nothing which can tell you the amount of suffering That no figures can tell us the amount of suffering that a patient or the family undergoes. One study was there which was published in 2018. It talked about patients, 1,600 patients waiting for oncology consultations in 4 major cancer hospitals in India, out of which 88% had pain when they came in, but after consultation, 67% of these either did not get any medicine or received inadequate prescriptions. So it goes to show that even in big tertiary care centers, pain is not routinely assessed, documented, and managed properly. And this is in spite of the fact that opioids have been part of our national list of essential medicines since 2003. And another very important concept is that pain relief is now supposed to be a fundamental human right, and that not being able to give pain relief to a patient is as bad as torturing someone, because the pain which is caused by the police torturing a prisoner or that caused by a disease for the patient is not different. And we must know that India is the largest producer of legal morphine in the world. But in spite of that, we have very few people writing morphine. We have very few patients able to get morphine. And all over the world, if you look at the figures, 6 countries, that is Australia, Britain, Canada, France, US, and Germany, these consume 80% of the legal morphine, whereas the developing countries, which have 80% of the population, they can get only about 6%. And again, on the WHO list of essential medicines, opioids have been there since 85. And in our country, in spite of the fact that so much of it is produced, but it's mostly exported because there is a lack of demand, and that's mostly because of fears of abuse and addiction, and also because the earlier laws were very stringent and it was very difficult to get opioids and use them. Now, a little bit about the background. In UN, a resolution was passed in 2005 which said that medical use of opioids is indispensable for relief of pain and suffering, and that it should be available at all times in adequate amount, appropriate dosage form for patients in pain, and that any country having low national consumption of opioids is a matter of great concern. Now, how much should we be concerned about India? This is a graph which shows global consumption of morphine mg per capita. And if you look at this graph, this was by the Pain and Policy Studies Group in University of Wisconsin, which shows that Austria, US, UK are here among the largest users. And if you have to look for India, you have to look really hard, and India is somewhere here at the bottom. And this is data from INCB, which shows the amount of morphine required for each person dying the last 3 months of life. So cancer, 80% of patients require morphine in the last 3 months of life. HIV, 50% require, and average requirement is something like 679 milligrams per patient. The amount which is available for patients in India is 0.4 milligram. So you can imagine the amount of suffering our patients undergo. Now, for a very long time, since the scientific developments started taking place, and over the last century or so, there has been so much of emphasis on investigations, on cure, that the idea of caring or for good prognosis, good pain relief has gone into the background. And apart from that, years and years of strict, stringent regulations and severe penalties resulted in the lack of availability of opioids for training in medical colleges, lack of experience, so that almost 2 generations of doctors have grown up without actually using oral morphine and being comfortable with its use. Whatever we have seen has been in the ICUs, injectables in ICUs, in acute care or in emergencies, and the huge amount of fears that we have about. I remember reading about morphine only in pharmacology as far as opium addiction was concerned or morphine addiction was concerned. We did not learn about pain management. Then there were strict rules which prevented interstate movement and inadequate awareness in government offices like excise and drug control. And also there was a huge resistance to looking at the medical and scientific use, and we were only looking at the drug addiction part. Also, because a lot of departments were required, almost 5 licenses were required, so that there was a lot of lack of coordination and lot of follow-up required. Also, another very important reason is that those of us who are working in tertiary care centers, even in secondary care, we are all aware that for patients in pain, if you write oral morphine, it is not there. But if you prescribe fentanyl patches, the MR will ask you, "Ki aap mujhe patient ka address bata do, I will go and deliver it to the patient." The rules for fentanyl patches and morphine are the same. Then why is it that fentanyl is so easily available whereas oral morphine is not available? If you look at this cost table, which shows the cost per day of different types of opioids, propoxyphene we do not use any longer, but tramadol, codeine, morphine, fentanyl transdermal, and buprenorphine patches. We can see that the cost of fentanyl patches for 3 days comes out to be almost 1,500 rupees, which is much beyond the availability for most of our poor patients. And pharma companies are just not interested. If they have low margins of profit, there's a low demand, and there's a lot of paperwork, a lot of bureaucracy involved, they will not be interested. And also because there's a lot of promotion of expensive formulations, so that oral morphine, which is the gold standard, which is very cheap, is not available for our hospitals. And for the patients, what happens then for the patients? Since supply is allowed for only a few days, patients have to travel. Now, over the last few years, things have improved, but earlier, I remember patients had to travel to All India Institute, New Delhi, from as far as Sikkim, Arunachal Pradesh, just to get 15 days or 21 days worth of medication. And it is so difficult for sick patients to be traveling. Attendants lose out on their job, on their work, on the money. And they have to stand in line from 7 a.m., get the doctor at 12. And if there is something wrong with the prescription, the pharmacy sends them right back to get it then, and they have to stand in line all over again. And this doesn't take into account the limitation on the prescription, doesn't take into account the fact that patients are different, their requirements are different, and there is absolutely no ceiling in the amount of morphine that you can give to a patient. There was a study at AIIMS. If you want, I'll find out the details for you. I was not able to locate that paper last night. There was this study of almost 12,000 patients in AIIMS who were on follow-up for pain management in palliative care, and they found that not a single patient had misused the opioids. But this was another study published by Dr. Raj Gopal and David Jorgensen in Lancet way back in 2001, which had a study of 1,700 plus patients in Kozhikode, and found that patients who were on oral morphine, both in OPD and home care, for almost 2 years, the study lasted, and they found not a single instance of misuse or diversion. But again, it stresses on that you have to follow up, you have to select, you have to monitor the patients, you have to have very good record keeping. But in both the studies, what they found was that oral morphine can be safely given to patients for chronic pain at home, chronic malignant pain, and palliative care patients, and without fear of any misuse or diversion. But you have to be careful with them. Again, there was this paper in Journal of Symptom Management published in 2017, which talked about how the reforms came around. So a lot of people in the civic society, palliative care community, and international policy experts, legal experts came together, and they fought for the amendment of the act, so that finally the NDPS Act was amended in 2015. And there was this central principle of ensuring balance, ensuring medical and scientific use, as well as prevention of diversion and misuse. So what happened when this act was modified? When the NDPS Act was modified in 2015, they simplified the procedures for stocking and dispensing of morphine. They reduced the paperwork, and they had a list of essential narcotic drugs. I'll come to it later. What are ENDs, essential narcotic drugs? And this law was now applicable throughout the country in all the states. Earlier, we had different rules in different states. You are aware that health is a state subject. And this law was also interpreted differently by different states, but after the modification, this is a single uniform rule, single act applicable to the whole country. And only one agency, that is the state drug controller, has the authority to recognize an institution for stocking and dispensing of morphine, opioids. It allows the institution to stock and dispense ENDs for 3 years, essential narcotics for 3 years, and you do not require multiple licenses from multiple agencies any longer. Now, a few important points about NDPS. What are the definitions we must know? What are essential narcotic drugs? These are opioids necessary for pain management as approved by DGCI, Drug Controller General of India. And this list includes morphine, methadone, codeine, hydrocodone, oxycodone, and fentanyl. In Western countries, many other formulations are available. In India, we still have only 4 of these, but this is what ENDs are. And what is an RMI? A recognized medical institution. What is the institution where you can have a stock of opioids? Now, any hospital, any dispensary, any clinic, any institution which has services for diagnosis, treatment, injury, deformity, which is maintained either by the government or by a municipal corporation or by a Zilla Parishad or any body of persons. That is, any medical institution can be a recognized medical institution provided it fulfills the requirements. Now, what are those requirements? An RMI, now what these are the requirements that an RMI must have, that is a trained person must be there, so that this has linked training in the use of drugs with the rules for stocking. Any health facility can purchase, store and dispense oral morphine once it has a person who is trained. It has facility for safe storage. It has secure facility to stock opioids in a double locking system. Now, a double locking system does not mean a locker like in a bank, jisme do tale, you know, 2 people having keys to 1 cupboard. It's not that. It just means a locked cupboard in a locked room. That is a double locking system. So a locked room, a locked cupboard, and basic staff who can monitor the patient and who can do proper record keeping. That is all that is required. So you need a trained doctor. You need a place where you can store opioids in a cupboard in a locked room, and you need properly trained staff to have proper documentation. And you have to have separate registers. Now, I will not go into the details of the forms. They are all given. I will send them an email so that, Pallium can circulate them to you. They are available on the net, but I'm just naming them here in the PPT so that whenever you need to have opioids or you need to know the details, they will be there in this PPT for you. Who is the doctor who can be trained? Any registered medical practitioner, either a doctor or a dentist who has undergone training in the use of ENDs. So basic process for recognizing is that you train a doctor, then send an application for RMI status to the drug controller. Drug controller will send somebody for inspection. The institution can be authorized. After that, they can purchase our ENDs, get a receipt of consignment, stock them, maintain proper records, file a return and renewal. So this is a basic chain which I have put in one diagram, and I will be explaining them in brief one by one. First step is to get a doctor or a dentist of that institution trained. Second is sending an application to the state drug controller, and this application has to be signed by the MS of the hospital or the doctor who is in charge of the institution. Now, sometimes this causes a problem. The administration, the person who is in charge will say, I will not sign, I do not know about opioids. But then it is for us to explain to them that they are doing it just as the head of the institution. Responsibility for opioids will lie with the person who is trained. Then copy of the degree, registration and training certificate of the doctor, and forms 3F, 3J, which have annual estimate of how much you need, a covering letter to the drug controller along with a self-addressed stamped envelope, a stamp worth rupees 27. Now, I also do not know why it is rupees 27 and not anything else. Why it is not 30 or 20, but it says 27. So it is 27. Then after you write to the drug controller, they will send somebody to inspect your institution or clinic. And once they send a representative, they might or might not send, but if they do send, then they will authorize your institution as an RMI, that is a recognized medical institution. And this answer they have to give within 60 days of getting your application. They will specify the quantity of ENDs which are allotted for 1 year. Now, please understand that this is not a licensing procedure. They are not giving you a license. Nobody is authorized to give you a license. They are only recognizing your institution as an RMI. There's a difference. Revenue department no longer has anything to do with this whole process. If your state or your state drug controller do not understand the process, then please have somebody from Pallium India, some senior person from the institutions in your state which already have palliative care, somebody from IAPC come over, have an online session for them, organize something, talk to them beforehand so that they are aware. Sometimes drug controller people may not be aware of the new rules and they may create a problem, but do make sure before sending your application that they do know of the new process and the new rules so that you don't face a problem. And for any reason, if they're not giving you permission, that also they have to tell within 2 months of getting your application. After you get your application, after your institution is recognized, then you can ask any pharmaceutical agency which is recognized. You send them your copy of RMI status and you ask them for opioids. You place a purchase order. After that, they will send your ENDs as they send other drugs, like all medicines we get in our hospitals. They will send a consignment in Form 3C. That original you will keep and the copy will be sent back to the supplier. But one thing we have to be careful about is maintaining records. All records have to be maintained for 2 years, and all day-to-day accounts of each transaction have to be entered in the format of Form 3D. Now, all these forms you will be getting, so you can see them in detail. And every consignment note that you get, you have to keep a record of this also. Amount of drugs that have been used have to be sent a file. You have to file a return for each calendar year on the 31st of the subsequent year in a given format, that is Form 3I, to the controller of drugs. And this annual requirement is, if you say we need 5,000 tablets, then you may hold 5,000 tablets at any given point of time. That's the upper limit. But if your 5,000 tablets are finished in 6 months, then it's not like you cannot get more. You can apply again and you may get another 5,000 tablets. So at any point of time, that's the maximum you can hold. But you may apply repeatedly if your thing is finished. But you have to only give a justification that our patients were more, or we did not estimate correctly, or patients died, or there was more requirement, whatever. So you just have to give a reason and you may get your drugs again. What about private clinics and standalone practitioners? What is the rule for them? Can they also stock ENDs? Yes, they can. You can have ENDs for emergency purposes in your own practice. That does not require any special authorization for a limited amount. Now, what is that limit? Morphine, not more than 500 mg. Codeine, not more than 2000 mg. Hydrocodone, not more than 320 mg. Fentanyl, 2 transdermal patches of 12.5 micrograms or 1 patch of 25 micrograms. If you need more than this stock, then you can apply to the drug controller in Form 3B. And this permission is for a period of 3 years. What about stocking of opioids? You have to purchase from only authorized chemists or dealers who have an opioid license, who are authorized to sell it. And this list is usually available with the state narcotic commissioner or should be available. If it is not there, you may ask for it. Sorry. They should be given to selected patients. You have to be very careful in prescribing opioids. One of the most overused drugs is tramadol in backache cases and given without supervision. Another thing is that unused narcotics which are returned by families can be considered receipts and taken into the store again. Supposing the patient dies, the family may bring back the unused morphine and that can be taken back into the store. If by chance your narcotics are expired, then they have to be destroyed in the presence of an official designated by the state drug controller. And if the doctor who is there, the RMP in charge of the ENDs in your hospital changes, is transferred or goes away or resigns, this has to be intimated within 7 days. And if somebody new comes in, then you have to get a reissuing of certificate with the details of the new doctor. So you have to excuse me for 2 minutes. I need to go and drink some water. I have a bad throat.
No worries, ma'am, please.
Sorry for the interruption. We'll start again. Oh, okay, so this was a paper which was published in AIMS, in the Indian Journal of Palliative Care. And this talks about the circle of safety when we are prescribing opioids. We need to have good trust with the patient, with the family, within the team, with our administration, and with the general public. Need to create awareness about the need and use of opioids in a safe manner. We need to empower our physicians and staff, train them properly in the proper use opioids responsibly, make sure that they are available for the patients who need them, educate the society at large, make sure that they are safely dispensed so that your staff in the pharmacy, the pharmacist, anybody else who assists the pharmacist should be aware how to use, what is the dose, what are the side effects, what are the records to be maintained properly, and the staff and patient both have to be supervised. And also remember the concept of total pain. Not all pains are responsive to opioids. Make sure we are not neglecting other causes of pain and don't depend only on opioids for pain relief. Do look at the adjuvants, do look at the other means of pain relief, TENS, complementary therapies, spiritual pain, psychosocial pain, support to the patient. And if the patient is not responding, always review. Have joint meetings with other doctors also, because they will learn about the concept of palliative care if the patient is happy and relieved. And also we need to remember that we should never let other doctors feel that we are taking away their patients. Territorialism is a very important reason why patients don't come to palliative care. So if you refer patients back, patients go back satisfied. Always send a note of thank you for a doctor who is referring, and let them see the difference that palliative care can make to the lives of their patients. All of this results in a safe use of opioids and generally a safe society without fear of misuse and diversion of opioids. But we must also remember, we must teach our young doctors and staff that opioids exist to be used. They are not just to be withheld from patients. And morphine in all these years, like aspirin, still is a beautiful, safe, effective, cheap drug with which we have a lot of experience. And especially as in developing countries, most of our patients are very poor. It remains the gold standard for management of severe pain. And we must always use it according to the severity of pain and not the stage of disease. It is not that patient who has very advanced illness only will have severe pain. We know that cancer pain can be very, very severe in early stages also, in patients who are in stage 2 or 3 also. And it's very important to make available our normal release formulations of morphine before we go on to sustained release, which is expensive, or fentanyl, or the other more expensive versions. But what do we need to do? Now you have been trained. Make sure that other people know about it. Make sure other health professionals know. Organize CMEs, make case presentations, talk about it to other people. General public should know, then policymakers. Law enforcement agencies are very important to teach about palliative care, because in narcotics, in police departments, now I work in the forces, I'm aware how little these people, if as medicos we do not know much about pain relief, then you can imagine how little these agencies would know about use of opioids in pain relief. Then we must make sure that we have palliative care at all levels of care. It is not just primary care. It is not just community care. It is not just tertiary care. You need to have it as primary, secondary, and tertiary. You need to have home care. You need to have respite care. And wherever we work, in whatever specialty we are, there are patients who are going to need this approach. You know, the definition says it is an approach. So your approach, your holistic care can make a lot of difference to the lives of your patients, whatever branch you are in. And you need to have good networking skills. You need to have good education and training for your staff. Once you are trained, you need to have a team around you. So you will need to get your nurses trained. You will need to get your community health workers, junior doctors, physiotherapists, pharmacists. If you have a good team, you will be able to give better output. And last but not the least, for those of us who can, I am aware that in India, there's not everyone who can do research work, but those of us who can do it, please look at palliative care topics for research. Encourage your students, if you're in a medical college, encourage other students in other branches to take up research related to palliative care, because we need more evidence. Nowadays, medicine has become more evidence-based, and we need to build up evidence for palliative medicine, which is relevant to our patients, the Indian patients in our scenarios. So please go ahead and do all these things. And this is what Buddha said is being wisely selfish. Whatever you do comes back to you. We are all going to die in the systems that we help to create today. So if we have good pain relief, if we would have good symptom relief, if we have good end of life care, it will probably be that will be available when our time comes. So thank you very much for your patient listening, and I'm going to stop sharing and we can have questions and answers if we need to discuss anything related to this.
Thank you, Dr. Savita, for that precise presentation. We already had one query from Dr. Roshan Kumar. He was asking, can patients or relatives give or return morphine back if they have extra or if they don't need any?
Yes, of course. And we should always explain to them, because morphine is precious. You know, morphine is like gold. Tell them that this is very precious. It's very difficult to get. Don't throw it away. Don't burn it with the patient. Don't bury it with the patient. Please bring it back to us so that somebody else who is in need can be given. And as I told you, it can be taken back as a receipt into the store. Just make sure you check the batch number, check the expiry date before you take it back, but you can. It's legally allowed. There's another question. If the patient lost morphine and informs us, then what should we do? In palliative care, we generally tend to believe what the patient says, but you have to make sure that it's actually lost, and you know, somebody is not misusing. So if it is one time loss, it's okay, but every 10 days they're coming and saying, you know, it's got lost, it's not findable, you know, something happened, then you have to be suspicious. So these things probably come with experience. You know, the first thing I said was trust. So it has to be trust for the doctor, but it has to be trust for the patient and family. But let them not fool you also. Then we prescribe codeine, tramadol or normal prescription, and morphine in a special prescription with a proper documentation. Then why it's not for codeine, tramadol, although they are ENDs? Very good question, I must say. See, when we use codeine and tramadol, they are scheduled drugs, but for opioids, you need a DD-12, a triplicate prescription, where you have details of the patient. I think next time I'll put in a slide for that also to show how we give a prescription. If we do not have morphine in our institutions and there is a local dealer or a chemist who does stock opioids, then we can write a prescription. There is a special format. You can find it on the web, or I can send it later. I can send it to Pallium and they can distribute it to the participants. You have to write the name and number of the patient. You have to give the address and phone number. Then you have to write which drug. Say you need to give injection morphine and you need to give tablet morphine. Then you have to give 2 prescriptions, separate ones. Injection we give separate, tablet we give separate. You have to give how many 20 mg tablet 4 hourly for 15 days. Number of tablets total, you calculate how many tablets and then you write that also. Your number, your name, your registration number and your stamp if you have one. So all of that and your phone number, we need to put all of that on the prescription. It should be legible, preferably in capital letters. And for separate formulations, we need to give separate prescriptions. It's a lengthy process, but believe me, it's very, very important. For those who are trained, you are precious people for India. So patient, you think of your patient and make that little extra effort. So one person is saying, Dr. Neelkant is saying, I'm working as a surgeon in tertiary care in Bhavnagar, Gujarat. Can I prescribe morphine? If yes, how? Of course, Dr. Neelkant, you can, because all doctors can prescribe morphine. What we said about training was about stocking in your institution. But you legally can, but it is always good to get trained and then write and then prescribe. So if you are interested, you are already undergoing this course, I believe. And by the time you finish, you will learn how to prescribe. And if you still have doubts, we are all there for you. All the faculty, believe me, in palliative medicine, you can ring up anyone, anytime, and everybody will be happy to help out. So in Gujarat and Ahmedabad, you have lots of people. I'm sure Bhavnagar will also have somebody who can help you out. So if you have any doubts about doses, side effects, anything you need to ask when you are following up a patient, just ask someone. Ask any of us. Then Dr. Urmila is saying, generally morphine is given for 2 weeks to palliative care patients. It should be increased at least 1 month to avoid the problems faced. Yes, of course. Very difficult to find the way when relatives say patient is on deathbed, not possible to bring them. No, we see the patient on video. It's very commonly done. We say that, for the first time, do bring the patient to us. We want to make sure the patient requires, we need to examine. Physical examination is also very important when prescribing opioids, even if the patient is on deathbed. We try to see. And if patient absolutely cannot come, then we try to have home care teams visit. Okay, then for the next subsequent visit, if the patient is not able to come, you can always see on video and you can give the medicine to the attendant. That's allowed. You have to take the details of the attendant. You check their iCard, note down the number, Aadhaar card, ID number, phone number of the attendant, take his signature, and then you can give the medicine to the attendant. We do it in routine. And for patients we are very sure of, we give medicine for a month. For those who are coming from very remote areas, and we have been seeing the patient for a while, we know they are trustworthy, we give them for a month. It's okay. So what to do as proxy attendance? For such patient is not allowed. It is allowed. It is allowed. We do it in routine. For patients who are dying, we really cannot expect them to come to us. So we either send the home care team or we check the patient on video, make sure the person is there, and give it to the attendant. And I think I forgot to mention here that now it is legally allowed. You can give a prescription and the medicine can be couriered or sent by post. So if you have a patient with you, but you don't have access to morphine, you can give a prescription hard copy to the dealer. You must have a list, Indian Association of Palliative Care and Pallium both have I think, list of approved companies which manufacture morphine and a few of their dealers. So get in touch with the person who is closest to you, tell them that this is the patient, and they will send by courier, but they will send it to the doctor, not to the patient directly. Then I think I have not missed Piche. Any question? I'll just scroll up and see if I've missed any question. I have seen a few metastatic survivors coming, especially for codeine. They're very happy with that tablet. What to do in these cases? Is it really an analgesic effect or a little bit of dependency? You have to see, you have to find out in detail what is it. And some patients can have chronic pain even after treatment for cancer. Neuropathy is very common, and chronic pain syndromes after treatment can be very common. Post-operative chronic pain is there. Neuropathic pain, CIPN, is very common. So please do assess the patient properly. And we cannot generalize, one patient and one family are not like the other. So find out in detail why the patient is taking what has happened, and then decide from case to case. Can you train, can an untrained MBBS doctor prescribe morphine? See, that is what I was saying again and again. You have to be trained. You are legally allowed. MBBS doctor can prescribe, but do you know how to do it? I would never write anything I don't know how to write. So get training, learn about it, ask somebody. You can use telemedicine, you can ask somebody who is trained, show them your patient, sit with them, ask them, how do I give medicine to this patient? And then you prescribe and get it. But don't do it unless you are not comfortable and you don't know. Then I think that's all. Any question I missed?
No, ma'am, not at all. So just adding to Dr. Nilkan's point, where Savita ma'am has already answered the query, we do have a session coming up with the state facilitation team on Monday, wherein you will get to know the details how our state facilitation team works in facilitating the RMI license parts and all that. And of course, the team will be helping you in procurement of morphine and other related medicines as well. So we do have a session coming up. I believe most of your other queries will be answered in that session. So please stay tuned for that. Any other questions which Dr. Savita can take up as of now?
So I think while people are thinking of a question, I will give you a very nice little story of a patient. Like they're asking now, is it just for dependency or patient really has pain? I was posted in Jalandhar, and we had a patient who came with an injection abscess, came to the surgical OPD. And then the surgeon said that, he has a history of dependence, addiction to tramadol. In Punjab, addiction is very common to opioids, as we are all aware. And he would go to the local market and get that from the gray market and inject himself. So I sat down with him and I started asking, and what I came to know was that patient had been treated about 10 years ago at All India Institute for Thyroid Cancer. He had had surgery, he had radiation, and after that, he developed radionecrosis of the jaw. His teeth fell out. He weighed, this man of 170 centimeters, weighed 57 kg when I saw him. Highly malnourished. He could not eat because there were no teeth. Nobody had diagnosed that he had thyroid deficiency because of the radiation. And he had chronic chemotherapy-induced peripheral neuropathy, severe. And that is why, and he was on morphine. And when he got posted out from Delhi to Nagaland, he was lost on follow-up. And nobody could find out why he was on, why he was having so much of pain. And this patient kept on looking for relief. Finally, somebody had given him Ultraset, and he found that he was better with Ultraset. So he kept on looking for people who could give him Ultraset. Actually, he was having undiagnosed chronic peripheral neuropathy, severe. And nobody found out what had happened. Plus multivitamin deficiencies, he was not eating. his wife used to put his food in a food mixer and make a kind of, slurry of that food and feed it to him. So what we had to work up with, his hemoglobin was 7. So finally what we did was we started him on thyroxine. And then another thing I forgot to mention, then when they found that he was on tramadol, they sent him to the de-addiction center. And the de-addiction center people stopped that medication and he went into narcotic withdrawal. He had to be put on a ventilator in PGI Chandigarh. And thankfully he survived. But after that, we had to put him on thyroxine, brought him up. We had to give him multivitamins. We had to get his dentures made so that he could eat properly. And his weight came up to 62. After 7 years, he was able to put on his uniform and work as a bus conductor and get back to work, because there were so many undiagnosed problems there. And then we slowly tapered off his Ultracet and we put him on duloxetine, gabapentin, NT combination and multivitamins. And finally he was okay after 3 years of hard work. But then he had a recurrence and died. But we were able to give him a decent quality of life for that much of period. So, always do look into these issues. There can be so many things underlying why the patient is asking for pain medication. So I don't think we have any more questions. Anybody wants to share an experience? Otherwise, we'll close for the day.
Only thank you messages coming in. And Dr. Parul has stated that you're an inspiration. So true, Dr. Shivani. Such things.
Thank you.
Definitely motivate us a lot.
Thank you so much. So can I take leave now? Yeah, thank you. Thank you so much.
With everyone's permission, ma'am. Thank you so much for joining, ma'am. I could realize that you are having a bad throat today. And in spite of that, you managed to walk us through the session so beautifully and then shared your personal experience as well. Thank you so much for that. Even though the session was short, I believe everyone benefited a lot from your fabulous session. Thank you so much. And
Thank you. Thank you.
We do look forward for such beautiful sessions in future as well, ma'am.
Thank you so much. My pleasure entirely. And I think we will share the documents I have earlier also sent for the earlier participants, but I'll send them again in the email, which you can give to them. That has a list of all the forms in detail, what they will need. And this PPT also, then they can use this PPT for training if they want. In palliative medicine, we say that copyright is right to copy. So please use this PPT for teaching others, making awareness for your administration, and use it as much as you can. So thank you very much.
Thank you, ma'am. Thank you so much.
Bye-bye.
And thank you everyone for joining in. So we are winding up very early for the day. With that note, this is Sri Priya along with Dr. Savita Butola signing off for the weekend. Have a nice weekend, safe weekend, and see you on Monday with another interesting topic. Till then, everyone, take care. Bye-bye.